All right. Good morning and good afternoon. Thank you everyone for joining today's APHRS education webinar, Heart Failure and Basic CRT, Part 1. My name is Jeremy Yu. I'm the Education Manager at Abbott Medical. It is an honor to be the moderator of this webinar. Today, this is a great opportunity to have two experienced implanter, Dr. Colin Yeoh from Singapore and Dr. Tina Lin from Australia, to share the knowledge on CRT implantation. If you have any questions during the presentation, please type them into the chat box in your control panel. We will bring them up after the presentation. Now I would like to introduce our chairperson of today, Dr. Giselle Gervasio. Dr. Giselle is the head of electrophysiology division at the St. Luke's Medical Center, Global City in Philippines. She is also the president of Philippine Heart Rhythm Society and the chairperson of APHRS Cardiac Implantable Device Subcommittee. Good morning, Dr. Giselle. May I invite you to give an opening speech and introduce our speaker for today? Thank you.
Yes, certainly. Thank you very much, Jeremy. So good morning to all our attendees from around the region. On behalf of the Asia Pacific Heart Rhythm Society, I'd like to welcome everyone, all the attendees who are signed in right now. We hope you enjoy the next 2 hours of fruitful discussion. So today will be the first of 2 sessions on cardiac resynchronization therapy. The subsequent months will have sessions on pacemakers and ICD. For those of you who have been with the APHRS for several years now, some of you may be familiar with the APHRS St. Jude Abbott device modules, which were previously held in Beijing. Now, obviously, with the COVID situation, we have had to be creative and have had to find ways to continue this very well-received activity. So the topic, as mentioned, will be on CRT for this weekend and 2 weekends after now. And when we talk of CRT, everyone is aware that this is already standard of care. Not only does it save lives, it also makes patients feel better. So we are actually very excited to be starting with this particular module. As mentioned by Jeremy, there will be 2 speakers featured this morning. And I would like to introduce our first speaker, Colin Yeoh, who is currently a consultant at the Department of Cardiology at Changi General Hospital in Singapore. Now, he did his bachelor's in medicine and surgery from the National University of Singapore in 2005 and became a member of the Royal College of Physicians in 2010. After which he obtained specialty accreditation in cardiology in 2013, completed his fellowship and his research in adult clinical electrophysiology at the University of Ottawa from 2015 to 2017, during which he served as chief fellow. So Dr. Colin will be speaking on the anatomy and tips for engaging the coronary sinus. So, Colin.
Thank you very much, Giselle. Welcome, everybody. It's a great honor to get an opportunity to kick off our CRT series. And generally, for CRT, we know that unlike the other 2-chamber systems, it's a bit tricky in terms of the procedure time because of the LV lead. And one of the reasons would be the challenges that you may face on cannulating the CS or the coronary sinus. So for this session, I will focus mainly on the anatomy and how we can engage the coronary sinus. And some of the things that we'll go through today, we'll be familiarizing ourselves with the tools to engage the CS. And the tools goes beyond the LV lead implantation hardware, but all the other hardwares that we use for the procedure. We like to appreciate the CS anatomy. We go through the strategies to engage the CS and how we can anticipate the challenges that you may face. So the fluoroscopy unit is obviously a key tool that we use. and we want to reduce the amount of radiation as much as possible. So this is something I'd like to highlight because I don't think it's receiving enough attention. And we are adjacent to the image intensifier unit when we are doing the procedure. Now for CRT, we spend a bit more time, particularly because of the LV lead implantation. We are next to the patient, so we are not just in proximity to the radiation unit, but also to radiation scatter, which is from the patient. So some of the tools I've learned, especially as a fellow, is really to make use of tools that are already available to you. So for example, the collimator is something we can use to help to reduce the amount of scatter that we can get from the II itself. And we try to reduce the amount of radiation by controlling the fluoro dose and the fluoro quality. So this helps to reduce the cumulative radiation dose you will receive. We minimize the use of cine because cine is really the aspect of it which has the highest radiation, and we generally reserve the cine for doing the venogram. And otherwise, most of the work we do for the implantation, we only need the fluoro imaging. And of course, depending on cath lab to cath lab, you may have access to 3D mapping, you may have access to a floating lead shield. This can also help to reduce the amount of radiation. And for us individually as operators, you also could, besides your lead aprons, also consider getting yourself a pair of lead goggles. So these are some of the things that to highlight. Now, as we go about doing the procedure, we have to also understand that the success of the procedure, the ease of the procedure starts before you're in the LV, before you even put hardware into the heart. So some of the things that I actually focus on would be actually on as basic things as venous access. So for example, the common venous access that operators use will be the subclavian and axillary puncture, and sometimes you may use a cephalic approach. The advantage of the cephalic is obviously you reduce the risk of pneumothorax to almost zero, but it is impossible to really squeeze more than 2 leads into a cephalic vein. So you are generally forced to use the subclavian and axillary puncture access. And if you do manage to squeeze 1 lead into the cephalic vein, I don't recommend squeezing 2 leads because it does increase the lead to lead interaction. So that's something you have to be familiarized with, the different access. And things you want to focus on is also whether you want to put in a left-sided or right-sided implant. I think most parts of the world, if it was a de novo device, you would usually put it on the left side. Generally, that's what most of the hardware is designed for. Most operators are right-handed, and generally it's much more intuitive to implant a device on the left side. Rarely we may be forced to the right side because of prevailing anatomical limitations. For example, the patient have had previous mastectomy, axillary clearance, or radiation to the right-sided chest, then you may be forced to, on the left-sided chest, and then you may be forced to go to the right side instead. Other things to consider would be whether are you doing a new implant or an upgrade. Now, a new implant is obviously the easiest because you don't have to deal with post-operative complications and fibrosis and stuff like that. But sometimes you are forced to do an upgrade because the patient already has a pre-existing device. Then you have to consider things, challenges such as whether there's any subclavian vein stenosis and SVC, superior vena cava obstruction, for instance. You also want to consider the number of leads on the ipsilateral side. Now, all these are important because it decides on whether you will need to prepare for any procedures to overcome the challenges. So, for example, if you have already anticipated possible stenosis, you may want to do a venogram pre-procedurally just to make sure that you don't have a stenosis. Or even if you do have a stenosis, you'd ask yourself whether you're prepared to do a venoplasty, or if you're not comfortable doing a venoplasty, then you may get a colleague to help you with the venoplasty. Now, if there's already hardware on the ipsilateral side, or if there's already quite a fair bit of leads down the SVC, then you will also have to consider whether you will need to extract the leads before putting in new hardware. And nowadays, we also consider about extraction for the sake of preserving MRI conditional status. So even if the patient only has 2 leads, for instance, on a pre-existing dual chamber pacemaker, you may want to consider extracting at least 1 lead just so that you do not have any abandoned leads, and so to preserve the MRI conditional status if you're putting in an MRI conditional system. And I think in today's day and age, we really try to give the patient an option on the role of future MRI. And the next thing is obviously cardiac anatomy. It's important because this is where you're going to be working on. Things that can really affect how you cannulate the CS will be the LV size. We are implanting a device in heart failure patients. So clearly there's a real possibility that LV is dilated, and this can cause the CSOS to be oriented more posteriorly. You will want to find out if the patient has a persistent left SVC, because this really changes the ball game. If you're going to put in a left ventricular, even an epicardial LV lead, for instance, if you have a persistent left SVC, it makes the procedure much more challenging. So for example, just taking note of any and dilated CSOS on echocardiography, doing a bubble test just to make sure that there's no persistent FSVC. These are surprises that you can overcome before you're on table. Go through the patient's history and just make sure that the patient, if they has a previous cardiac surgery, you want to know what kind of surgery the patient has had done before, get the operative notes, because sometimes this can affect your procedure. Particularly the patient has had a previous mitral valve surgery or a tricuspid valve repair, for instance. This can affect your CS anatomy and the challenges that you may face. If the patient has had previous pneumonectomy, for instance, it will also cause the heart to be rotated. And this will also make your CS cannulation that much more challenging. And then comes to the very fundamental question: which leads do you want to do first? You want to put in an LV lead first, you want to put in an RV lead first, or you want to put in an RV and RA lead first, followed by the LV lead? They all have their own pros and cons. There's no right or wrong. We'll go through that a bit during my slides. Now, as we go to the basics, as we get access, one of the things that I'd like to focus on is really to separate the punctures. We are having 3 leads into the EC lateral side, so therefore you just want to space them out, even though they all eventually come into the subclavian vein. By spacing out the punctures, you can also help to reduce the risk of any lead interaction as you tie down the different leads. And as we went down the road of discussion before, if you are going to do an upgrade, for instance, it is useful to do a venogram either before the procedure or early upfront in the procedure so that you can anticipate any challenges. So in this case, even before I run the image, you will notice that there's already some collaterals. And that is a suggestion of a stenosis in the subclavian vein. Now, as you run it through it, you can see that there is some flow going through, but clearly there's wasting on the subclavian vein. So this is at least a challenge that you're asking yourself. This is a patient with a pre-existing VVI pacemaker, and even then it can cause a narrowing of the subclavian vein. Then you can ask yourself, do you think you can get through this, or do you think you need to use a venoplasty? Now, if you do see a stenosis that is a little bit beyond the distal, a bit off the medial border of the first rib, you may want to do your puncture a little bit more distally. In this case, for example, a bit distal, nearer to the distal border of the first rib, so that you could just get a bit of a toe hole on the vein, and then you can just put in the lead a little bit with a bit more support. Sometimes the usual J-tip guide wire may not get you through it, and in this case, I use a hydrophilic thermo guide wire to go through the same stenosis that you saw earlier. So in this case, I managed to get through the stenosis without the need of venoplasty. So all these little things will highlight to you, because if there is pre-existing stenosis, sometimes it makes torquing the LV delivery system a bit harder. Now, as you know, a CRT is a longer procedure compared to ICD or pacemaker. So you really want to set up your hardware, your equipment in a little bit more ergonomic way, just to minimize the pain, literal pain in the neck for you. All right, so we know that the tables of the patient can be adjusted. So therefore, you like to choose an equipment table that is of certain height, so that it can ideally be on the same height as the patient when we do the procedure during the LV lead implantation. This is a suggested orientation, and this is how I personally do my procedures actually. Instead of having the equipment going parallel to the long axis of the patient, we make it perpendicular to the patient. And the reason is so that there is no kinking of the system. The catheter system just basically goes directly to the pocket, whether it's left pocket or right pocket. The assistant stands on the right-hand side of the operator. This facilitates the assistant on doing things like contrast dye injection, passing equipment, and passing the hardware to the operator. And the X-ray is just across the patient. And this allows the operator to just turn to his left to have a look at the procedure and not at the foot of the patient, which will literally give the operator a pain in the neck, especially if it's a long procedure. So all these little things helps to make a potential challenging case, especially if you are new to CRT, a little bit more comfort, a little bit more at ease as you go through the procedure. You prepare some of the hardware. As we talked about getting venous access, you also talk about the sheaths that you want to use. There are different choices. You can use a sheath. There's a slittable sheath or peel away sheath. You can use a sheath with a valve or without a valve. So personally, I use a safe sheath, which comes with a valve, and it's a peel away. The advantage of a sheath with a valve is that it mitigates any backflow and makes your operative site a little bit drier, a little bit cleaner. The downside, some people don't like it, is with the sheath. Sometimes people feel it, there's a little bit of resistance when they do clock and counterclocking. Personally, I'm okay with that. You want to make sure that you flush the sheath with heparinized saline, and you want to test your balloon that you're going to use for occlusive venogram. You want to prepare your contrast. So normally I'll prepare at least 50 ml of contrast, diluted 50-50 for the scouting and for the occlusive venogram later on. And you want to decide how you want to inject your contrast. You will need contrast during the implantation as you scout for the CSOS or during the venogram. If you read the chapter by Dr. Seth Worley, he will talk about using a Y connector connecting to the syringe. That's one option. For those who are used to doing PCIs, for instance, you may be very comfortable using a manifold. So that's also very reasonable. Or you can just use a direct syringe injection. You just have to be very sure that the syringe does not have air bubbles as you connect and disconnect the LV delivery system. So these are the different options that you may want to consider. Now, as we do fluoroscopy and use fluoroscopy to guide our procedure, it is imperative that we are familiar with the strengths and the weakness of the different fluoroscopic views. And fluoroscopy is a two-dimensional view of a three-dimensional organ, which is the heart. All right, so looking at the LAO, or the left anterior oblique view, we know that the strength of this LAO view is that it helps to tease out between the right side of the heart and the left side of the heart. Here we have the decapolar through the coronary sinus. So you know that this is where the CS would sit, and this is where the CSOS would be. The strength of this view, besides the left and the right, is really to tell you the anterior and the posterior aspect of the heart too in this way. And similarly, in the right anterior oblique view, it has a different strength compared to LAO. It doesn't tell you the left from the right heart, but it does tell you the RA from the RV, the atrium from the ventricle. And therefore, it again helps to tell you where your catheter is in relation to the heart. And here, you will see in this part anterior to the heart, and this is posterior to the heart. Now, as you go to the CS anatomy, the few key landmarks that we're watching out for, besides whether you're in the atrium or the ventricle, is really the other finer structures. The structures you will be familiar with will be the tricuspid annulus, which is the more ventricular aspect of the structure that you'll be facing with. And this will be something that you may notice when you do your contrast dye injection. And as you try to go back to search for the CS, or some of the structures that you may come into contact with will be the eustachian ridge. So the eustachian ridge will be guarding the IVC if you're coming in nearer to the IVC aspect of it. And in order to cannulate the CS, you will come into contact with the Tebesian valve. And sometimes you may have trouble entering the CSOS because the Tebesian valve guards the CS, especially from the inferior aspect. And which is why many a times when we cannulate the CS, we come from a superior-inferior approach. Now, we've come a long way since the LV delivery system was introduced in the market, and we are really thankful that they have been a better design now since the old days. And I cannot help but really emphasize the need of these curves, the proximal curves, which will help you in your procedure and makes it a little bit more easy to cannulate the CS. So in this case, this diagram and a few other diagrams subsequently are taken from the textbook by Ken and Bogan, the Clinical Cardiac Pacing, Defib, and Resynchronization Therapy textbook, something that you can really consider for a reference text. In this case, it's nicely illustrated how the proximal curve is supposed to sit nicely to the posterior wall of the right atrium, resting along the eustachian ridge to cannulate the CS. Now, this is important because if you're using a CS guide that does not have adequate support, even if you manage to cannulate the CS in this case, you can see that there's absence of the proximal curve to rest against the right atrial structure. There is an undue torsion as a result of your cannulation without support. This becomes a problem when you try to cannulate, and becomes a problem when you're trying to desleeve the LV delivery system. You may have seen how when people try to desleeve the LV delivery system, it actually draws and pulls out the LV lead. And this can happen because of the lack of support on the CS guide, because of the absence of the proximal curve. And as a result, as you start to desleeve the LV delivery system, this torsion that was stored up is released and therefore comes out pulling the LV lead at the same time. So these are things you don't want to happen to you after you've had the effort of delivering the LV lead in the desired branch. Now, this is really a good illustration on how we cannulate the CS. Now, we cannulate the CS in this case generally from the SVC, right? Unlike the EP study, which sometimes you can cannulate from IVC. As you cannulate the CS with the catheter coming from the SVC, in position 1, you can see that if you're, for example, coming in from the right atrium, you generally do a counterclock maneuver so that the tip of the LV catheter would then go more posteriorly, as you can see in position 2, as correlating to the diagram here. And as you counterclock even more, the LV guide points more posteriorly and points more inferiorly. And if you remember the diagram earlier, this allows the LV delivery system the appropriate angle to cannulate the CSOS and get across the Tebesian valve. At the same time, the proximal curve of the LV guide would then come off the posterior more and come out more anteriorly. So this is how the CS guide orientates and rotates as you do the counterclock maneuver. So it's important to appreciate how the CS guide responds to counterclocking if you are in the right atrial orientation. And if you do end up more or too posteriorly, then you may have to clock a bit more to come back to point towards the CS. Okay, as we previously mentioned before, as you are putting in the leads, every operator has their own preference. So some operator likes to put in the RV lead first. And the advantage is that, after all our patients, or most of our patients with CRT, have left bundle branch block. And while you're trying to cannulate the CS, your CS guide may hit the right bundle and it may induce complete heart block. And some operators don't like to handle the risk of having a complete heart block, so you can put in the RV lead first to just provide backup pacing in the event of complete heart block. Personally, I also use the RV lead also as a landmark to know where the tricuspid annulus is, because as you give some slack to the RV lead, you can see that there's a curve along where the tricuspid annulus is, so you know that the CSOS will be somewhere about in the tricuspid annulus, just a more posterior aspect of it. In fact, the proximal end of the RV coil is typically where the CSOS would be. And later on, you will see some of my fluoroscopic images that highlight how consistent the CSOS is, unless there is a gross orientation of the heart. Now, some operators like to put in the LV lead first, and the advantage is there's no hardware, there's no lead for you to interfere with your CS guide, and there's no lead for you to be fearful of dislodging it. Obviously, the downside is if you do ding and knock out the right bundle branch in a patient with left bundle branch block, then you have to deal with the transient complete heart block. And of course, very commonly, operators will want to put in the RA and RV lead first. The downside to this is that you may risk dislodging the RA lead, especially if your RA lead has quite a lot of slack dangling along the tricuspid annulus. Then that is literally where your CS guide will be clocking and counterclocking, and that's where you may risk dislodging the RA lead if your CS guide cuts through the curve of the RA lead. I don't think there's any right or wrong. It's up to individual operator preference to choose whichever leads to go first. The next thing is, of course, to be familiar with the CS delivery system. All companies, Medtronic, Boston, St. Jude's, Biotronic, they all have very similar curves. They all have the basic curves. So generally, they will have a few tools for right-sided implant. The straight guide obviously is not very helpful if you're using just a straight guide to cannulate the CS. You would normally need a deflectable EP catheter to use a straight guide. There are curves that are meant for right-sided implant. And then the different curves, depending on the size of the right atrium, and depending on whether you like to cannulate the CS from above using a more gentle curve, or attacking the CSOS from below using a wider curve. There's also something called the inner cannulating guide. In this case, I'm just giving an example of the St. Jude system, where they have the AL2 and the CSL, where you can telescope these inner guides from the outer guide to cannulate the CS. Now, some companies do have a little bit more options compared to other companies. So I will have to, I personally feel that I'm okay with all four brands, but you should be familiar with the different curves and the different terminology that the different brands are using. Now, some labs are not forced to use a delivery system of the same brand as the device that they're implanting. So that's great. You can choose your favorite delivery system regardless of the brand of equipment you're using. But if not, you should be familiar with what your equipment is. If you're new to CRT, I would recommend that you stick to one delivery system so that you're really familiar with it. And then subsequently, as you're more familiar, you're welcome to try the other brand's delivery system. But generally, I think they're all quite similar as far as the standard curves are concerned, in terms of their talkability and in terms of their stability when we slit them, for instance. All right, so this is a reminder again that the reason why we choose a different curve will be really based on the anatomy that the patient has, particularly in the right atrium, and how the LV may be enlarged. In this case, you can see fluoroscopically with a smaller RA, for instance, your CS angle of attack is generally not as steep. But in a dilated RA, for instance, the angle may be higher, the CSOS position may be higher, and therefore you may have to use a more gentle curve, for instance, to cannulate CS. Now, you can make a best guess approach based on experience, using prevailing investigation results to make a best guess on which delivery guide you want to use. I think as you gain experience, different operators have their own preference. And again, there's no right, no wrong. You just have to use your experience and interpret the patient's specific anatomy to see how and which RV delivery guide you want to use at the beginning. And again, an example, again, in a patient with a normal heart, the CS could be cannulated from below. But if you have a dilated heart, for instance, again, the angle changes, the CSOS height changes, you may have to change the approach from an inferior approach, you may have to cannulate the CS from a superior approach. Okay, so this is an example of how I use the proximal end of the RV coil to estimate where the CSOS is. And then I cannulate, in this case, I use a guide wire to try to cannulate the CS to confirm where the CS is in the LAO projection before I use the CS guide to cannulate the CS itself. We will go through this a little bit more later on. So a little bit of evidence-based approach. So our VGH colleagues from Taipei published a paper a couple of years ago where they found that really in their series of patients, all of their patients' CSOS in the LAO caudal view, 2020 view, they're all about within 3.7 centimeters from the heel of the RV lead. The heel of the RV lead in this view corresponds to the tricuspid annulus, and therefore the CSOS is always either below or above the heel. Gives you a little bit of a focus target to focus on. And if the LV is dilated, they found that this was a big reason why the CSOS is found inferiorly to the tricuspid annulus. Otherwise, the majority of their CSOS were found superior to the tricuspid annulus based on the LAO 20 caudal 20 view. When they found that the ratio is small in the LA to LV ratio, this was the statistical reason why the CSOS tends to be found inferior to the tricuspid annulus, and mainly is driven by LV enlargement. So this is something that you can use because all patients would have pre-existing echo imaging to help you to understand how you may want to cannulate the CS. Now, cannulating CSOS, which is the real meat of it, where I guess you are all itching to do it whenever you do a CRT case, and everybody have their own preference. Personally, this is my first go-to using a guide wire. The pros of using a guide wire is that you don't need to use contrast for this aspect of the procedure. You will definitely need to use contrast during the occlusive venogram, but if, for example, if the patient has pre-existing chronic kidney impairment, for instance, then you may want to minimize the contrast use and hopefully get away with cannulating a CSOS with zero contrast and just focus the contrast on the venogram. So in this case, I use the proximal coil of the CS. I use the guide wire to search. I counterclock a bit more, counterclock, and yet it pops in. So I can just use the CS guide wire to confirm that in the CS and just cannulate the CS in this way. Now, incidentally, this patient has a previous mitral valve replacement, which can be a boon or a bane to you as an operator. Obviously, the boon is that it tells you where the mitral annulus is. The bane is that you never know how the surgeons may have distorted the CS. There's no way the surgeon is going to talk about this in his operative notes. And you will only find out for yourself either during the procedure or you go to the extent of doing a CT heart to look at the CS anatomy. Okay, so if it's a straightforward case, this is how it's going to look like in cannulating the CS. Now, if you read the chapter on CS cannulation by Dr. Seth Worley in the Ken Edelmogen's textbook on pacing, you will realize that he will emphasize the role of using contrast to identify where the CSOS is. Now, the strength of using contrast is you can see which structures you're in, which chambers you're in. So in this case, we shot some contrast. You can see there's trabeculation, so you know that you're in the RV septum area. So even though we are so-called near the proximal end of the RV coil, but you're still not at the CS. Because don't forget, you're looking at a 3D structure, which is a heart, using a 2D fluoroscopy. Now, other structures you should be familiar with if you are using the contrast method to scout is to identify if you are in the right atrium. So in this case, you can see that this guide is clearly much superior to the RV coil and RV leads, for instance. You can see the smooth vertical angle of this structure, and that will be the right atrium. And if this was in the LAO view, then you can be sure that this is in the interatrial septum, for instance. And then if you want to come lower down, you can see that now there's a little curvy line here, which will correspond to the tricuspid annulus. So you know that you're in the more atrial structure, and you are more in the tricuspid annulus in this case. And then you can adjust your CS guide accordingly. And you know that here in this case, the CSOS is much lower and a little bit more posterior. So you can counterclock and advance your CS guide accordingly to try to cannulate the CSOS. Another structure you'll be familiar with is the sub-eustachian space. So in this case, when we inject dye contrast, you can see that the dye is already lighting up this very well-defined structure space, and this is here where you're stuck behind the sub-eustachian space. Now, if you're stuck in the sub-eustachian space, the good news is you know where the CSOS is. The sub-eustachian space is inferior and at a more atrial aspect compared to the CSOS. So in order to move to the CSOS, you would pull back your CS guide a wee bit, maybe a centimeter or so, and clock it about 20 degrees so that you will then move a bit more anteriorly and then advance the CS guide so that you'll be just nice at the CSOS area. Okay, so therefore it's important if you're using the contrast scouting method, that's the advantage you have to have a better idea, especially in a challenging case, to know where you are and to cannulate the CS accordingly. So again, this is another case of mine. And you can see that there I've identified the CSOS as I inject the contrast dye. Okay, it's just at the level of the CS guide, but just at a different angle. Okay, and then therefore this is where your target is. That's where your CSOS is, lighting up the CS. Okay, so this is my personal second line of defense if I cannot get the CS using the guide wire method. Now, sometimes you can identify the CSOS, but you have difficulty cannulating the CS because you don't have enough support. So you can use, like I mentioned earlier, you can use an inner guide to help to cannulate the CS. So in this case, I've used the guide wire approach to cannulate the CS, but for some reason, I couldn't quite bring my outer guide into the CS, so I used the telescoping method, where I use the inner guide to advance into the CS. With the inner guide in the CS, it gives me more support to then advance the outer guide into the CS. So this is another strategy that you can use. Now, this is another method that you can consider. This was a method that I used to use when I was a fellow. Because that's what the bosses would love to use. Basically, you used to use a deflectable CS guide to cannulate the CS. The advantage of the CS guide is that it is deflectable. It is a tool that you're familiar with if you do EP studies. And it has adequate support. It is stiff enough to support the outer guide. So you do not need to use the inner guide to give you support to advance into the CS. You can just railroad the outer guide via the EP catheter. The downside is that some operators believe that the CS, some operators believe that the EP catheter is quite stiff, and therefore it may dissect CS. I mean, if you have been doing EP studies, you would know that the CS catheter or the decapolar, it is a stiff catheter, but it is not super stiff. And after all, we use it routinely to cannulate the CS. So it's quite okay if you are gentle and don't just ram the EP catheter straight into the CS branch, for instance. The other advantage of using a EP catheter or a deflectable decapolar, for instance, is that you can connect up to the Procar or EP recording system, and you don't need to just depend on fluoroscopy or contrast dye, but you can use your EP readings to look at the typical CS EGMs, looking at the sharp A and the far field V, and you know that's where the annular signal is, and that's where you can then focus on looking for the CS. The other advantage of using the deflectable EP catheter is that you can use a straight outer guide, for instance, to cannulate the CS. So this is a boon again for you if you are going to cannulate the CS from the right side, doing a right-sided implant. Okay, from here, then you can see I can just railroad the outer guide into the CS. In this case, I actually use the unplugged outer sheath to cannulate the CS. If you're really desperate, if you really cannot find a CSOS, this is about my only time that I've used this method to find the CS, which is using coronary angiography. You could give enough dye, and you need to cine long enough into the venous face, and there you are. You can identify the CS. You can see the CS down here into the CSOS here. So if you're really desperate, this is something you can do to try to cannulate the coronary arteries and really to identify where the CSOS is. And from there, ideally, you should be captured in two views, LAO and RAO, and then therefore go on to search for the CSOS. Okay, so challenges. One of the challenges would be obviously for a right-sided implant. And for a right-sided implant, you don't have too much of a choice. In this case, I was using the straight guide. The straight guide is not particularly pre-shaped, so it gives you a little bit more malleability as you use a deflectable EP catheter to cannulate the CS, and then use the straight guide to cannulate the CS by railroading through the EP catheter. So in this case, this is how we did it. Okay, to cannulate it. Now the right-sided implant has its own challenge because most of us are right-handed. We are used to implanting devices on the patient's left side, and therefore a right-sided implant is just a little bit awkward most of the time. In this case, besides a straight outer guide, you may want to consider a right-sided guide to try to cannulate CS. You can see the shape of it looks a bit different. In this particular case, even with the right-sided guide, we couldn't quite cannulate the CS. And see, we can give some contrast dye injection, we end up in the RV instead. So no matter how we try to counterclock, we could just never quite go posterior enough to cannulate the CS from the right side. And again, this is how important it is to really anticipate the challenges so you know upfront the tools to use and to have the different strategies to use. Eventually, we managed to find a CS in this case, and we used the deflectable EP catheter to cannulate the CS. And in this case, my outer guide was the unplugged CS guide from Medtronic to cannulate it. All right. as you can see, it is not our first or second line for right-sided implant, but you use whatever you have to use to cannulate the CS. And it turns out that this CS was very posterior, and that's why we have so much difficulty. So you can see the CSOS is down here in the RAO projection, and how much of a torque the implants had to go in to cannulate the CS. So this is a kind of very high risk procedure, high risk because during the desleeving process, there's a high risk that as we desleeve the CS guide, it may pull out the LV lead. Now, if you are used to the Medtronic delivery system, the Medtronic also has a specific guide for very posterior CSOS, which is a 3D CS guide. It's called the 3D CS guide, and you may want to consider using that for such cases. Another challenge that you should anticipate would be if the patient has a mitral valve surgery, as mentioned before earlier. The advantage is you know where the mitral annulus is. The downside is that sometimes the CS could be, anatomy could be distorted. So we're just thankful that at least in this case, we could still cannulate the CS, although we can't really quite see the typical CS, main CS anatomy. We just see a main lateral branch. So we're not sure whether this anatomy or is this because of the post-surgery approach. But this is something that you want to take note of if the patient has had a previous mitral valve surgery. Also, sometimes unusual anatomies for you to take note of. So in this case, we use telescoping AL2, and it subselected the lateral branch. And in this case, the lateral branch bifurcates from the main CS very early. So if we had cannulated the main CS and did a venogram, we may not visualize this lateral branch unless we hold the cine long enough to see the venous filling phase. So in summary, it's important that you know your tools well, not just your LV delivery system, but also all your other equipments, including your tabletops, your fluoroscopy unit, where you place your fluoro screens, for instance. Give yourself an ergonomic platform to work with. Be familiar with the cardiac anatomy, be familiar with different views on fluoroscopy, identify the challenges specific to your case. Every patient can be very different. And also be familiar with the different modalities to scout for the CSOS. You will choose a preferred method and then have some other backup methods if the case turns out to be more challenging. And with this, I'd like to thank you very much for your attention.
Thank you very much, Dr. Colin, for your sharing and engaging the CS. And hi, Dr. Giselle, do you have anything you would like to add to this topic?
Yeah, thank you and congratulations first to Colleen for a very clear and simplified lecture. It makes it sound so easy. And I was looking through the APHRS website. The APHRS website has a white book which contains a census of all the implantations. And for 2019, the whole Asia Pacific region had a total of 14,500 CRT implants, which obviously is a very small number compared to the number of heart failure patients with dysynchrony that we see on a regular basis. So as the head of the device subcommittee, it's telling me two things. One is that there is really a need to build up the level of knowledge and the skill, and two, to make the patients as well as the referring physicians more aware of it. So for today, for the discussion on the skill, I think Patrick did a good job, and basically I took home the following points. One is that you need to know your anatomy. Those of us that do ablations, when you do especially slow pathway ablation, you will easily fall into the CS, and it's in a lot of cases easy to fall into the CS if you're in the right region, if you know your anatomy, where to start clocking or counterclocking, where to start straightening out your catheter. Also, the adjustments, like as mentioned, if you have chamber enlargements, then that would distort the anatomy. That has to be taken into account as well. And then also, one needs to have a strategy. I think using a venogram is a smart strategy in terms of minimizing the amount of contrast that needs to be used, and especially as mentioned for upgrades where you want to have a good estimate of the probability of being able to cross any slightly obstructed vein. So 3, you should have your tools, know your tools. I personally also use a long table because having the catheters laid out straight and having your assist on the side with all the catheters laid out just takes out a lot of the tension needed when you're trying to squeeze a lot of hardware into a very small space. And then I would also like to add that for the young electrophysiologists or even the young implanters, the device subcommittee is also encouraging proctorship. So after you've attended a didactic like this one, please feel free to approach your APHRS representative, country representative, or even our corporate partners like Abbott. And we will be more than happy to set up a proctorship to help build the experience. Because like any skill, practice makes it so much easier. And I think only when we have achieved that level of confidence will we be able to better serve our heart failure patients. So back to you, Jeremy.
Thank you. So with that, we will go ahead to take some time for questions. It looks like we have a few questions here. The first question is there any tips to tackle prominent Sebastian valve? Any role of non-invasive imaging before the procedure, especially to identify the character of the CS? Doyo, do you have any comments?
So I'll tackle the second question first. Generally, you can do a CT, cardiac CT to look at the veins. I've never really done that myself before, but if you think that the patient has had a previous cardiac surgery, I think it's not unreasonable to consider doing a cardiac CT, specifically looking out for the CS veins, which the coronary veins and the CS itself. So you have to specifically tell the radiologist or the cardiologist is doing it to time it accordingly. The prominent Tibial valve, generally you will have to use venography to really have a better idea. So if you are somewhere at the CSOS, get a good path of the valve. Ideally, if you can, 2 views, and just so that you can know which angle to attack to get through the valve. So you have to choose either whether you usually you either tackle it from high to low or low to high, depending on how the valve is oriented.
I might, if you don't mind, I might add a little bit to that. I also, if it becomes very difficult and the Sebastian valve is very big, I do sometimes consider coming from inferior, as in through a groin approach. Use a normal CS as an EP, normal CS catheter to get into the CS so that you can pull the valve down and then cannulate from above, and that might open up the CSOS a little bit as well. That could be another option.
Mm-hmm.
Thank you. And let's move on to the second questions. The shift LV lead, then RA lead, or put in RA lead first, then let's shift LV lead. Okay.
Personally, I just focus one thing at a time. So when I get my LV lead in there, I usually de-sleeve the LV lead, and then if there's any other leads to do, then I'll do the other leads. I've seen other people, other operators leave the sheaths in and fix on the other leads first before de-sleeving the LV sheath or the LV guide. The reason why I do the de-sheathing up front is if it's unstable, it's unstable. It comes out, it comes out. It comes out while doing the table. Whereas if you leave the big CS guide in there while you're playing around with the RA lead and RV lead, and then you disleave the LV lead, you may end up dislodging the other leads too at the same time. So usually I go one lead at a time, tackle the LV lead completely, including disleaving the LV sheath, then focus on any other task at hand.
How about Darlene? How's your practice?
I also would deal with the LV lead in its entirety itself, but I do put the RV and RA lead in first, and then put the LV lead in last. And therefore the RA lead is already in.
Okay. And here's another question is for early bifurcation, how many frequent we've seen in patients, and what is trick we know to know this patient have early bifurcation?
Many a times I find out on table that there's early bifurcation. So usually when I do the occlusive venogram, which I'm sure Tina will be talking about later, I make sure that I hold the cine long enough to see the venous filling phase. Because while you see the clear-cut veins up front, sometimes during the venous filling phase, you light up the other veins which the os of these smaller veins may be nearer to the CSOS itself. So therefore may not immediately light up when you do the occlusive venogram, and only show up during the venous filling phase. So by then you would have seen the bifurcation. And then if you realize that there is truly a bifurcation and that is your only choice, then you may have to pull your CS guide further out nearer to the os and try to cannulate this bifurcated branch. Is there a lag there?
It looks like the, can you hear me?
Yeah,
Yeah.
there was a lag there, is it?
Yes, yes, a bit lag from Hong Kong. Yeah, I think it's all right now.
Okay. Sorry, where was I?
Yep. I hope that you have already can hear your reply to the questions. How about another question is, can you give us the reference of the LAO 2020 caudal view?
Oh, okay. That is actually at the bottom of my slide. So I think if it's going to be a recorded segment, the reference is at the bottom.
Okay.
It's a 2012 paper by Xian Chen's group.
All right. In the interest of time, I think we take one more questions before we move on to Dr. Lin lectures. How to avoid a CS dissection when going CS venogram as catheter? But about the CS wall? Okay.
So I think it really, you have to be gentle. You can just assume that this is your own heart or your loved one's heart. Just be really gentle when you cannulate the CS. And don't force it in. Okay, some guys, especially when you're starting out, when you can't go in, you just force it in, so you shouldn't. So that's why we don't jam the whole CS guide right into the CS. We usually use something softer to enter the CS and then railroad the CS guide into the CS. And then I'm sure later on, and Dr. Lin is talking about doing the occlusive venogram, there'll be some tips again, because sometimes you can dissect the CS when you shove the balloon tip into the CS wall, because it is also a stiff tip. So generally, the key word is to be gentle and don't force your way through.
If I may, yeah. So
yeah, please.
I find that the guiding catheter is usually quite forgiving. It's usually the balloon that is the culprit for the dissection. but also know that even with a dissection, you can still save the case by not losing the true lumen. If you are still in the true lumen, then you can still put the beam.
All right. Hey, here's one more. I think I can get comments from all our speakers and chairperson. What is your choose if you don't find CSOS? What is the next step if you can't find the CSOS?
Okay. So it's extremely unusual not to find a CSOS unless the patient has had some kind of cardiac surgery that you think that is tied up and strangulated the whole CS. So you can do the coronary angiogram method because that will surely light up whatever CSOS if there is one. And yeah, and then from there you can go on. Usually you will find some kind of CSOS, it's just that the CS may be very distorted. Now, if you really cannot find anything, then obviously there are some much less uncommon methods previously. You can close up and do a CT again just to delineate where the CS is. And if there's really no CS, then you may want to consider either epicardial pacing, or there used to be consideration of endocardial LV lead placing, which I done a couple of cases during my fellowship training. It is a pain to do it. And then of course, today we have something called his bundle pacing. So in our lab, we've been doing a couple of his CRT cases, especially for non-left bundle branch block patients. And it's great. So I think we have some options nowadays.
Right. Thank you. Thank you. I hope you have covered all some of the questions from our audience. Before I pass the time to Dr. Giselle to introduce Dr. Lin, just a friendly reminder that the APHRS CRT module Part 2 will be held on 25th of July, again at the same time on Saturday. For those who can attend both Part 1 and Part 2, you may apply certificates of attendance from APHRS. Please contact APHRS Secretary or through ABBOT representative to apply for the certificate. So now I pass you the time, Dr. Giselle. Thank you.
Okay, so we are keeping good time. Dr. Tina Lim is going to be talking to us on the coronary sinus lead positioning. And Dr. Lin graduated from the University of Melbourne Medical School in 2004, after which she went on to complete her advanced training in pacing and pacing fellowship at the Austin Hospital, Heidelberg in 2012. There she was awarded the prestigious European Heart Rhythm Association Fellowship, and she studied for 2 years there under the guidance of Professor Karl-Heinz Koch, who was recently the ERA president. And in that same hospital, she trained in EP studies and complex arrhythmias. Currently, Tina runs the Victoria's largest remote device monitoring service and shares her expertise by co-supervising the Austin Health Cardiac Resynchronization Training course. So, Tina.
Thank you very much. Let me see if I can share my screen. Give me 2 seconds. So sorry about the delay. Thank you everyone for coming here, being here today on a Saturday morning. That's the first thing. I know we're all spending our free time here to be able to listen to us. And thank you very much for giving me the opportunity to have to talk today, to be involved in this series of lectures on cardiac resynchronization therapy and the management of CRT and optimization of this over the 2-week series. Just had an excellent talk from Colin to talk about CS anatomy and engaging a CS, which is in some circumstances quite a complex process, and the first part of a process that can sometimes be quite difficult. and the reason for this is because accessing the vein, the CSOS or the vein, is almost a blind process, even though there are things that we can do to increase our chances of knowing where that CSOS could be in a heart that is inevitably almost always remodeled in a heart failure patient. So my talk is going to be on what to do once we get into the CS, once we access the CS, how we can move that LV lead to where we anatomically want it to go. And then once we get it to where we want it to go, do we leave it where it is, or should we look at a best position for it? So once we get into the CS, we need to know what the CS anatomy generally should look like, or what it could be, so that we can guide that LV lead to where we want it to go. So if we look at just a diagrammatic view of the CS, we know that there are many branches that branch off the main body of the CS. And we know that the first branches are usually the middle cardiac vein, which eventually, if we look at the RAO view, will go to the apex of the LV. Then we've got the posterior, lateral, and the anterior lateral branches, which are the middle branches along that CS body. And then the branches that come down the front. Sorry about that. So they're down the anterior and then the basal part of the LV. And if we look at the different views in LAO, we want to aim for these lateral branches here anatomically. And in the LAO view, we want to aim for that middle part of the heart. We know that the studies have shown that if we put the LV lead in the apical areas or the basal areas, that although some people will have outcomes that are that will have response to CRT, that most of the patients who respond to CRT have their LV leads put anatomically in these areas as an anatomical assessment. So if you look at again at the RAO, LAO fluoroscopic views, these are the areas where we want to land anatomically those that LV lead. So Dr. Yao did talk about the venogram. So once we get into the CSOS, how can we visualize the CS for our particular patient who's on the table in front of us? As we know that the branches, although we do have some standard ideas of where the branches are, they can vary from patient to patient. How can we visualize it so we know where we can target these leads and therefore select the right lead to place? And also to allow us to know what our possibility of success is at putting that LV lead where we want it to go. So the venogram is probably the best way that we have once we're in the heart to see what the veins are available, what veins are available to us for that particular patient. So the setup is generally what the setup we have for the venogram. And the idea is to try and put that balloon, the occlusive balloon, as close to the CSOS as we possibly can with stability, and then injecting that contrast to be able to light up the vessels. You can see that if we place it ostially enough, we can actually try and hopefully be able to capture all those branches, even the early bifurcating branches as was shown in the previous talk, and even the middle cardiac vein as well. Okay. And I know that in the previous talk and with the questions, there was a discussion about being able to visualize that the early bifurcation and then the complications that can occur. And I agree with Dr. Giselle that there is a likelihood of dissection of the CS with the balloon, the inflating of the balloon, and that's generally associated with that balloon being inflated too much, and just being careful, as Dr. Colin Yao has said, in regards to injecting the contrast. And by highlighting the vessels with the contrast injection, we are able to see the branches, but also the size of the branches there, and therefore allowing us to choose between bipolar leads or quadrupolar leads or the size of the leads, and also be able for us to see the tortuosities and the takeoffs of the veins so that we can choose whether or not we need to use further equipment to try and access these veins. We'll also be able to see if there's any valves that maybe may make it more difficult for us to access a more distal vein branch, or stenosis, which may need different techniques to try and overcome. Once we know what the veins look like, it's a choice of what lead we should choose to get access to that lead. And nowadays, to increase the availability of vectors to allow us to pace the heart, we generally will be looking at something like a quadrupolar lead with the different sizes, which means a smaller S shape with closer pole spacing, or even a bigger S shape with wider pole spacing, or even a canted lead, such as this one here. If the veins are all quite small or tortuous, and we may decide that it may not be as easy to get the lead as far into the vein as we would like, a bipolar lead may need to be used. And there are active fixation leads that are available. This one from Medtronic, the latest one that has become available, where this spiral hook here, allows fixation of the lead in place and reduces the likelihood of that lead retracting or dislodging. So generally, to advance the LV lead, you can start off, I generally start off with the stylet inside the lead. And once we get the lead beyond the sheath, I generally don't have the stylet all the way in, as this increases the stiffness of the lead and therefore increases the risk of dissection of the lead. However, there are different stylets that are available, including a combination stylet and guide wire stylet, which means that the tip is quite soft. If the stylet guidance doesn't easily place the LV lead into the branch of the CS that we'd like it to go, I would then swap it across, swap the stylet across to a wire, an angiographic wire, for example, a BMW wire, and use the over the wire technique to cannulate the branch of the CS that I want the lead to go into, and then a push and pull technique to get the lead into the position that we'd like it to go to. If there is a specific, especially tight angle, for example, for the branch of the CS, there are inner sheaths and subselectors that can be used with all different angles to help guide that angle. And an important thing to know what the angle and what sheath to use and what angle we may be faced is with that the venogram that we would have performed at the start in different angles, which can sometimes show us that where we think the CSOS is and the angle of that CSOS branch is maybe different at different angles. If the LV lead is difficult to advance due to, for example, the vessel being too small, or the angle of the particular branch, or tortuosity of the branch that we want to get the lead into anatomically, then consideration of wiring or double wiring or buddy wiring to anchor the lead or the sheath in place so that we can advance the lead can be considered. Occlusive balloons can be used to anchor the sheath to help advance the lead. If there's stenosis, we can consider using angioplasty techniques, just like our interventional colleagues would use to try and open up stenosis. And here, down in the corner, is a picture of a snare technique where we wire the branch of the CS with an angiographic wire, for example. And if we cannot advance the lead over that wire, we try and pass that wire all the way back into the body of the CS as much as possible, and sometimes even back into the right atrium if possible. We use a snare to grab onto that wire so that we can anchor it and allow us to be able to pass that LV lead further along that wire, further along that branch of the CS. to where we want it to be. The important thing to remember when we use the snare is that we don't pull the wire tight. The heart is a muscle. It's soft tissue, so we don't want to cut through that muscle if we pull that wire too tightly. So once we get the LV lead in the position anatomically where we want it to go, should we just leave it? I guess that's the main question. We've taken all this time to be able to get that access that CSOS, and then we've moved that LV lead where we anatomically have got good separation, where we know that most of the studies have shown that we get good heart failure response if we place that LV lead anatomically to that LV lateral wall as much as we possibly can. Do we just leave it there, or should we look at other aspects? Well, and why do we do CRT? In the end, what is the point of CRT? And the point of CRT is that there is a lot of evidence behind CRT and patients' response to CRT from heart failure. We have had evidence with CRT trials for over 20, 30 years, since the 1990s. We know that there is good response rates from the multitude of studies with thousands and thousands of patients that enrolled in these studies, which show that the success rate for CRT is up to 70 to 80% response, with up to 30% super responder rates. And in experienced hands, LV lead implantation success is greater than 95%. And the evidence has been shown in studies that are now household names really in our world, with names like MADIT, CRT, the RAFT trial, reverse trial, companion trial, miracle trial. All of these names we've heard again and again and have been reanalyzed again and again to look at the different sub-analyses that we've been able to obtain from the thousands of patients that are involved in these studies. And we know that because of these studies, we have been able to define guidelines, and these are the guidelines throughout the world, from America, from Europe, and from us. And we can see that if we select the patients well, the evidence shows that patients respond well as well. Therefore, patient selection is still the gold standard to optimize response to CRT. And at the start of this talk, we talked about anatomically how we position that LV lead. And there have been studies to show that we can use, there is evidence, there's some evidence out there that we can anatomically position that LV lead where we have shown best response. We can use pre-procedural, we can use echocardiographic optimization and look at AV delay optimization, where we try and program the device with the shortest AV delay without truncation of the A wave. We can look at VV delay optimization to look for the largest stroke volume on echo Doppler. We can look at speckle tracking to look at maximum LV desynchrony and to look for response with minimization of LV desynchrony post-procedurally. We can look for patients with the typical left bundle branch block pattern of activation of the heart for patient selection. And we can look at the desynchrony index to also guide us as to what is a likely response for a patient. We can use other imaging such as cardiac MRI optimization to look at where the most delayed areas of the heart is and where the scarring is. And we can also again look at the contraction of the LV and that U-shaped contraction that indicate left bundle branch block contraction pattern versus something like an interventricular conduction delay. And using this information, we can use that before the procedure to decide where we anatomically would like to position that LV lead. However, if we go back to those guidelines and have a look at what specific parameters are used or what specific criteria have been shown to be able to, for us to be able to select the right patients to respond to CRT, we can see that almost all of the criteria are about the electrics of the heart. Well, other than defining that patient with an ejection fraction that's less than 35%. The rest of the criteria are looking at QRS duration, left bundle branch pattern, a rhythm that will allow us to be able to have a high percentage of resynchronization pacing, or a way to be able to, for us to be able to increase that CRT pacing. So a lot of these, most of these criteria are about the electrics of the heart. We know, therefore, that LV leads placed in areas of viable myocardium are more likely to respond. If you have an area of non-viable myocardium, we're not going to be able to pace the heart, or we're going to have a decreased amount of activation of those myocardial cells, and therefore decrease our success of resynchronization. The areas of dyssynchrony, if we place the LV lead in areas of dyssynchrony, we have a high response to CRT. And therefore the LV lead target position, other than knowing what the anatomical position should be, where we should be aiming for that LV lead, should be looking at areas of late activating LV segments electrically. So one of the earlier studies and earlier ways that we've had to look at the electrical part, electrical assessment of where we should put the LV lead, was looking at QLV. Dr. Singh in 2006 looking at an electrical assessment of areas of late LV activation. So QLV is the time between the onset of the QRS on the surface ECG to the sensed LV EGM. So if we look at the picture here, it's the start of the QRS going to the LV EGM, and QLV is that distance here. And what this initial study showed was that in patients who had a response, most of those patients had an QLV or an LV delay of more than 50% of the QRS complex. And the LV lead electrical delay, or that QLV, was significantly longer if the lead was placed anatomically in the lateral posterior lateral wall. So that's linking back to that anatomical assessment of that LV lead position. The SMART AV trial in 2011 included 426 patients looking at the assessment of QLV and response to CRT. They divided the patients into QLV quartiles of 0 to 70 milliseconds, 70 to 95 milliseconds, 95 to 120 milliseconds, 120 to 195 milliseconds. And what they showed was that there was a significant difference in LV and systolic volume response rates between the first quartile and the fourth quartile. And there was a significant response, in quality of life, again, between the first quartile and the fourth quartile. There was also evidence of reduction in heart failure events. So from 12% to 6.3%, which was a trend, but a definite improvement in New York Heart Association class, with significant improvement in between the first quartile and the fourth quartile. So this is a summary of this, but looking at each of the quartiles, you can see there is, in every parameter that was assessed, improvement, which is statistically significant. So in left ventricular end systolic volume, left ventricular end diastolic volume, left ventricular ejection fraction, and quality of life. But interestingly, we can see that this differentiation seems to almost be around the second and third quartile. So they've then split up the quartile 1 and 2 and 3 and 4, and they show that if the QLV is less than 95 milliseconds versus more than 95 milliseconds, this showed a statistically significant difference in all of these 4 parameters. So summarizing that, between the quartile 1 versus quartile 4, left ventricular end systolic volume response rate increased from 39% to 68%. Quality of life response rate improved from 50% to 72%. And in patients in quartile 4, there was a 3 times response overall increase in response. And the best response in kilo-V was greater than 95%. In 2017, a further parameter was assessed, and that was interventricular conduction delay. So that is the delay between the RV EGM to the LV EGM. If we have a look at this example, the RV EGM to LV EGM was shorter in this first example versus the second example. And what this study showed, but there was an overall significant clinical composite score improvement in those with longer RV to LV delays. So more people improved and less people had worsening overall composite clinical improvement. And what they saw was that with a cutoff of 67 milliseconds, there was a statistically significant improvement in heart failure-free survival with longer interventricular conduction delay versus shorter interventricular conduction delay. In 2014, we had a look at whether we could use a different parameter or find a different parameter or a combination of different parameters to see if we can further measure the electrical measures to improve response to CRT. And we looked at echo at baseline and echo at 6 months, and these different parameters to see if there was any improvement and what parameters could cause these improvements, particularly left ventricular ejection fraction, and also symptomatic improvement. The LV lead was targeted to the LV segment of latest mechanical activation, or the adjacent segment, which was assessed on imaging before the surgery, before the procedure, as an anatomical assessment as well. And the reason why is we sometimes don't always target the area of latest mechanical activation is because that area is often likely an area of scarring, and therefore we talked about viable myocardium versus non-viable myocardium and resynchronization of that tissue, or that there may be an area of functional delay that might affect that latest mechanical activation that may lead to less success in resynchronization. So the electrical measures that we measured was interventricular conduction delay, so internal RV to LV, as per the previous study. If we put the lead in and we saw that the internal RV to LV was less than 60 milliseconds, we would reposition the lead without testing for other parameters. Then we looked at RV pace to LV sense and LV pace to RV sense, and we used that to calculate a delta LV, which is the difference between these two parameters. Give me 2 seconds. My apologies. So I'm giving an example of what we measured. The intracardiac EGMs is basically measured from the RV EGM to the LV EGM. And for example, here it's a 63 millisecond delay. Here is an RV paced to LV sensed EGM, which we measured at 137 milliseconds, and an LV paced to RV sense EGM, which we measured at 131 milliseconds. And what we showed was that responders had a longer interventricular conduction delay versus non-responders, which was statistically significant. And that responders had a shorter delta LV versus a longer delta LV, which is statistically significant. We also showed that an intrinsic RV to LV delay of greater than 100 milliseconds had a response rate of 87%. Those with less than 100 milliseconds had a response rate of 68%. Patients with a delta LV of greater than 40 milliseconds had a response rate of 56%, and those with a shorter delta LV of less than 40 milliseconds had a response rate of 85%. So a trend with the intrinsic RV to LV delay to LV ejection fraction improvement, and a statistically significant association with delta LV versus ejection fraction. In regards to QLV in these patients, responders had a longer QLV, a trend towards a longer QLV, sorry. We got a cutoff of about 75% of the QRS complex as between response rates that are higher versus lower. So what we felt with this study, this study showed is that if we can get a significant distance between the RV and LV, it indicates that there is, and we can resynchronize that. It means that we can electrically bring in that LV contraction or that asynchrony in the LV contraction. But positioning that LV lead in an area that is not affected by functional block or functional activation may improve resynchronization. And that functional block is demonstrated with that with a prolonging of the delta LV, where if we pace in one direction, we may be able to activate to the other lead. But if we pace from the other direction, that getting through that functional block may take longer resynchronization and therefore lead to less response. So looking at multi-point evidence, we know that using multi-point, we may be able to activate a larger area of the LV, myocardium, increase the speed of impulse propagation, and hopefully reduce LV activation times. And this multi-point study in 2017 demonstrated an 87% clinical response rate overall, with turning on multi-point leading to 100% response rate in non-responders at 3 months. Dr. Leclerc in 2019 looked at a very large number of patients subsequently and with multi-point pacing. And they were able to show that there wasn't actually a difference between traditional biventricular pacing and multi-point pacing, which is a surprising finding from this study, but that they showed that a wide anatomical separation in multi-point pacing demonstrated better conversion rates as a trend overall. So indicating that probably if we can resynchronize and decrease that electrical activation of the left ventricle, we probably can get better resynchronization and response to CRT. So what can limit us in regards to, other than getting anatomically that lead to the optimal location that we would like it to be, what are the limitations to the electrical of a lead positioning that we can run into? So things like LV lead instability, phrenic nerve stimulation, which we have tried to overcome by introducing quadrupolar leads and increasing the vectors that are available to be able to activate the LV lead, and high thresholds, as we are dealing with myocardium that is most likely going to have some scarring in it in areas where the activation is going to be affected, or scarring where we cannot activate the heart. We know that eventually approximately 5% of LV leads will eventually be abandoned. So what happens when nothing works that particular day? We can come back another day, and why we will do that as compared to looking at another method is that the patient will have a different set of circumstances. We would have a different set of circumstances, which might change our success rate in that position the LV lead. Patient's fluid volume may be different. We may have encountered vein spasm and not seen a particular vein that we could access at the next attempt. Have a fresh look. We're not 2 or 3 hours into a procedure and tired and frustrated and therefore we might be able to get that lead in the position that we want a bit easier. And we also don't want to expose ourselves as well as our patients to too big a radiation and contrast dose if we run into a difficult implant. We can get someone else to have another go. We all put in leads in a little bit of a different way. That's to do with training, that's to do with what we've adapted and how we put an LV lead in. Can just be a small difference that mean that lead goes in versus someone else. And then eventually we can consider something like an epicardial lead, which of course is a bigger operation. I'm just going to talk, given that I'm talking about the electrical part of CRT, I'm going to quickly just mention his bundle pacing. And I know there's one of the comments that was in the chat as well. So the HIS-SYNC trial was a small trial that looked at his bundle pacing versus CRT. And the primary outcomes was looking at reduction in QRS, looking at ejection fraction improvement at 6 months, and looking at cardiovascular hospitalization or death at 12 months. Interestingly, the results showed no difference in QRS reduction, no difference in LV lead improvement, and no difference in cardiovascular hospitalization or death. But there was evidence that there was a higher pacing thresholds in his bundle pacing. And you may all know that a lot of the trials are looking at slowly increasing his bundle pacing threshold over time, now that we have had more time and more evidence doing his bundle pacing. The reason why I wanted to mention his bundle pacing is the HIS optimized CRT that Dr. Yo did mention just before. At the end of last year, HOT-CRT was published, and it was looking at patients with HIS pacing plus an LV lead for resynchronization. We know that cardiomyopathy patients have LV dysfunction due to cell-to-cell coupling issues and decoupling, which causes interventricular conduction delay. We know that it affects our conduction system and causes left bundle branch block patterns, but most of these patients are likely to have a combination of both issues, and both left bundle branch block and interventricular conduction delay may coexist. It may look like one or the other more so, but it's probably a combination issue. So the idea is that his bundle pacing with sequential LV pacing may improve resynchronization by resynchronizing the specialized conduction pathway, but also the myocardial cells as well. So they looked at a small number of patients again, non-consecutive patients, and they looked at patients who did not respond to HIS and put in an LV lead. So this is an example of what they were seeing in regards to electrical resynchronization. So patients with a baseline, for example, of 210 millisecond delays in the QRS, with HIS bundle pacing, with reduction of their QRS to 146 milliseconds, but not enough of an improvement that we would prefer or would like in regards to that electrical resynchronization, and including the LV lead CRT component, reducing that QRS down to 110 milliseconds. So the HOT-CRT results showed that their patients on average had a QRS of 183 milliseconds. With HIS bundle pacing, there was narrowing of the QRS in a large number of patients. With BIV pacing, there was a significant reduction in the QRS. With HOT-CRT, there was a further reduction in the QRS. So if we look at these numbers, HOT-CRT led to a statistically significant reduction from baseline, from bi-V pacing, and from his bundle pacing in regards to QRS restoration. They saw that the LVE ejection fraction improved from 24 to 38%, with super response in approximately 28 patients. There was significant reduction in a lot of the echo parameters and also clinical improvement as well. You can see that most of these improvements, all of these factors, are all statistically significant. In non-responders to bi-V pacing, they included 4 of these patients only, but they're looking at these 4 patients. They also showed that there was response in 3 of the 4 non-responders that were included to bi-V pacing. The baseline QRS with bi-V pacing of 196, sorry, a baseline QRS of 196 milliseconds with bi-V pacing down to 162 milliseconds, with the introduction of his pacing to 168 milliseconds without the LV component, but a combination of the LV lead as well as the HIS lead, a reduction in the QRS to 129 milliseconds. And they also showed in these patients there was an LV ejection fraction improvement from 20% to 29%. Again, we've got to remember that this study did only include a small number of patients, but we can see that a lot of centers around the world are starting to consider doing this if we cannot get initial response with either bi-V pacing or HIS bundle pacing. So what is next out there? There are people doing or studies looking at left bundle branch pacing itself. So either through the right atrium into the left septum or through the mid septum to access the left bundle branch. Could we consider left bundle branch pacing plus an LV lead, HIS bundle pacing with RV lead for other bundle branch blocks, such as the right bundle branch block? These are all possibilities because we know that cardiomyopathy with all the different types of electrical dyssynchrony, electrical issues is a complex process, and probably one method is unlikely to correct the problem. So just in conclusion, in the end, the target of why we're doing this is to improve outcomes for our patients. The electrical assessment is intra-procedural and allows us to be efficient in adjusting what parameters adjusting what we can in regards to parameters, and is adaptable as compared to optimizing a patient after the procedure, for example, with other forms of imaging. And the likely future is that we'll probably need a combination of different pacing techniques to allow optimization of the patient, of our patient care. Thank you.
Thank you very much, Dr. Lin, for this enlightening lecture. It's always good to learn some techniques to improve the responder rate. Dr. Giselle, do you have any things to add on to these topics, or any questions for Dr. Lin?
So there are a number of questions in the chat box. And one of them is how to avoid CS dissection when doing the Venogram. I think Tina mentioned earlier, avoid inflating the balloon too much and be gentle with the handling. But in addition, I'd like to add that you never advance the balloon out of the sheath. What you do is you pull the sheath back over the balloon to expose it before you inflate it. And that way you don't leave the sharp tip free to dissect the endocardial surface of the balloon. Additional comments I have pertain to technique. First is, I find that some people, as they do more CRTs, tend to not do the balloon occlusion. But I think that this is not a good practice because it limits the visualization of the branches, which is, I think, one of the more important aspects in deciding the optimal lead placement. Another observation is if you don't inject hard enough, you may not light up the branches adequately, and you may have a underfilling of the branches, leading again to false information. The subselector I found is very useful for the acutely angled branches, and I think many implanters share the love of this subselector device. Tina mentioned the use of a buddy wire or straightening techniques to straighten out the tortuous branches to improve the chances of advancing the lead. Another thing I sometimes do in my practice is if I cannot enter the lateral, or if there's no adequate lateral or posterior lateral branch, I will go as a second resort to the middle cardiac vein and go up through the apex, assuming it loops back up towards the lateral basal portion of the heart, and that's another possible site of implantation. But the other things Tina mentioned, I found very useful. Obviously, patient selection is the key. This is expensive technology. We want to provide a reasonable chance that the patient will respond. If the patient has a class 1 indication, then he has the best chance of responding. Things you can do pre-operatively to identify target areas might help, like imaging techniques to define scarred areas and to define viable areas. The QLV, I find is very useful because it's something that you can do intraoperatively and will markedly increase your chances of success. In studies, they have found that it's actually intraventricular desynchrony that is even more predictive of response rather than interventricular desynchrony. And then finally, post-op, you can still try some things, but as Tina mentioned, the best way to ensure response is to select patients properly, to select the branch, the optimal branch, and to do all the corrections intraoperatively. Back to you, Jeremy. Oh wait, I have a question for Tina.
Yes.
How, in your experience, how often are you having to change your initial branch selected on the basis of the electrical parameters measured? That's the first question. And the second question is, do you share the same experience of having to use the middle cardiac vein in some cases?
We, in definitely my practice with the people that I work with, we would generally not leave an LV lead if we think that it is not electrically in a good position, unless there is nowhere else that we can go. So I will always test, and I use QLV and I use that delta LV as well. That delta LV includes interventricular conduction delay. So that's the reason why we look at all different parameters and we try and find the position of the LV lead that will hopefully give the patient best response. So I do move that lead. We don't try to just leave it anatomically where we think it would be potentially the best place. So we definitely use electrical desynchrony and resynchronization as a parameter of where we leave that lead. I definitely do sometimes have to use that middle cardiac vein as long as it comes around. So it comes around the apex and it comes back up to that LV wall. With quadrupolar leads, it has made it much easier to be able to cover a larger area in regards to where we can position that lead. But I definitely do put that LV lead sometimes through the middle cardiac vein. And I think, although I don't use that snare technique that much, that may help us be able to push that LV lead beyond that apex and up that lateral wall as well.
Mm-hmm. Okay.
Thank you.
Questions in the chat box. Jeremy, take care of it.
Okay, great, thanks. Hey, how about Dr. Yo? You in John Yi Hospital? Is it similar approach like Dr. Tina Lin? In selecting the branches, or when are you going to choose to move your lead? How's your practice with you in Changi?
Yeah, so similarly, the patient selection is the most important. And with quadripolar leads, we have more leeway, more forgiving in terms of area of coverage, in terms of thresholds, in terms of phrenic capture. So if, for example, we go to a lateral branch and it may not be great in QLV in a particular pacing vector, you can try other pacing vectors. And of course, it is poor despite supposedly in the textbook version of a suitable target, then you may have to move to other lateral branches just to get it. Although sometimes we are left with Hobson's choice. We don't have a choice sometimes. So again, with that one vein, we will try the different pacing vectors to get a way out of it, or sensing vectors.
Okay, thank you.
Here, Jeremy, on whether fluoroscopic distance between RV and LV correlate with electrical delay. Martina.
So the studies that were mentioned did show that there was correlation with electrical separation with anatomical separation. Not always, because of course electrical activation is affected by scarring and decreased viability of the myocardium, but there was correlation.
Mm-hmm. Okay. And another question on, do you think physician practices in general do QLV measurements for every available branch to find the longest QLV? Or do most people just be practical and end up, going to the most lateral or posterior lateral branch they can reach?
So I think in the ideal world, we should. So definitely we should try. But I guess if we've spent an hour trying to access the CSOS and then another hour or an hour and a half trying to get the lead into one difficult lead that's available, sometimes that is what we have available and we have to leave it. We do have to think of, again, that the radiation exposure, the contrast exposure to that patient. So keeping that in mind, ideally we should use those factors to try and electrically optimize within a case, as well as the factors beforehand and after the procedure to optimize the device.
Just one point to suggest. So nowadays there's also an option called the biotronic vision wire. So if you don't want to try cannulating and testing every vein, you could also use the biotronic vision wire to measure the QLV on certain veins that you think that you can cannulate, and therefore minimize the need to cannulate and find that it's a lousy QLV.
Thank you. And another question, which is about implantation technique. For pacing the LV lead, do you use a vein selector to enter a vein, or pace the lead over a wire? What vein selector would you choose to use? Dr. Dean, do you have any comments on that?
Well, I think that depends on how in each specific case. I would always, as a start, use the angiographic wire or a guide wire to get into the vein and see if I can advance the lead without a vein selector. I actually find the vein selector sometimes very difficult to move inside the large sheath. So I definitely would try and do it without a vein selector. But if we need to use, if the angle is bad or we just can't get into that vein, that's when we should use the vein selectors. But that's what I would do.
Right. And another question is, during the follow-up CRT patients, which one is better to access the patient a 12-lead ECG or echo or functional class echo improvement? What about Dr. Yo or Dr. Giselle? Do you have any comments on that?
Okay, I can start first. So usually immediately, first of all, you've done whatever you can do during the implant. Immediately post-implant, where we have the 12-lead ECG, I would usually use the 12-lead ECG as a guide on which pacing vector to use. Nowadays, with this IS4 system, there's a variety of pacing vectors that you can you can paste from. So and you have sync AV, you've got MPP, you've got all kinds of algorithm now. So really, that's what Tina mentioned, it's really predominantly an electrical test. We know that previously there's a CRT echo study that really put the final nail to the coffin of echo-guided CRT. So really, we try to use the ECG to help. I mean, the QLV is extremely helpful in the lab, but ultimately I will use the 12-lead ECG to aim for the narrowest QRS. And of course, to make sure that there is some pre-excitation of the LV.
My practice is the same. I will intuitively look at the QRS and find the area with the narrowest QRS with the biparticular pacing and with the multiple pacing. But there are a lot of measurements taken for us when we apply the CRT toolkit. Like it will automatically give you measurements for all the combinations for the QLV, so that becomes easier. And then you combine it with the threshold phrenic nerve factors to ultimately decide which tools. But one observation is if you had to use multiple pacing, it would drain the battery like in half the time. So if you can find a good bipole, that would, I think, work best in terms of balancing device longevity and effectiveness.
I see. What about Darlene? And is it similar practice with you in Australia?
So I think the question is, yes, the answer is yes. So to assess how I would program the device, I would be looking at the 12-lead ECG. Once we have done the intra-procedural electrical measurements, once the procedure is finished, I would use the 12-lead ECG to choose the best vector and to look for the narrowest QRS and the LV predominance in the activation within V1. But in the end, down the track, that echo assessment, in the end, we are looking for heart failure improvement and ejection fraction improvement. So we would use the imaging techniques to assess for response.
Right, thanks. So let's take the last questions. What is the best wire for tortuous wings? If a wing is stenotic, would you dilate or go to another wing? About Dr. Lin? Any comments?
I start off with a, I get given the wire, but no, I'm just kidding. I would start with a BMW and I will use a stiffer wire if needed. And so a heavyweight wire versus a middleweight wire can be considered. We can sometimes use that initial J wire for stabilization. If a vein is stenotic, I would, if there's an alternative vein, why not use that vein? So I think I would try to go for another vein first. And if that stenotic vein is the only vein that we have available, then we would use the technique to try and open it up. Nothing's without risk. So if we dilate or angioplasty a vein, there's some risk associated with it as well.
How about Dr. Yo, any comments?
So I don't think a wire is a problem. Usually the wire goes wherever we want to go to. Yeah. The problem is the lead delivery. So usually the lead doesn't follow the wire if it's too tortuous or if it's stenotic. So I agree with Tina. I would not make life so difficult for myself. If there is an alternative choice, why not choose the alternative choice? But if you don't have a choice, the question is really which LV lead would you want to choose? And then the kind of support that you have for the LV lead for delivering the LV lead. Usually the wire is not a problem. Personally, I use either the BMW or the Whisper moderate support. These are my workhorse wires.
Right. Thank you. I think this is almost the end for this webinar. So here I want to thank you, Dr. Giselle, Dr. Lee, and Dr. Yo for your presentation and sharing of today. And I also want to thank you everyone for joining today's webinar. So now I would like to invite Dr. Giselle just to give us our final remarks of today.
Yeah, so it has been a most fruitful 2 hours. We had a very good discussion on the anatomy, CS cannulation, lead positioning, and other issues. We look forward to the next, the part 2 of this session on CRT, which will be held on July 25. At that time, we will be discussing indications for CRT and the problem of non-response, which is quite a significant problem. And we will have an equally distinguished panel of lecturers at that time. But also thank you very much, Tina and Colleen. You delivered very clear lectures, which I hope the audience will be able to apply in their practice. We encourage so that we will be able to better help our heart failure patients. Finally, APHRS would like to thank Abbott for supporting the program of education as far as device management of rhythm disorders. Thank you, Jeremy and Patrick, and see you in a couple of weeks.
Thank you. Thank you, Dr. Giselle. Just a friendly reminder that for those you all registered for today's webinar, you don't need to register again. So, and you shall receive a reminder, email reminder for the next CRT part 2, the day before the webinar. So you don't need to register again, okay? So now, thank you very much for all our speakers. And I hope every one of you are staying safe and healthy. And I look forward to the 2 weeks later, the CRT part 2. Okay, thank you and goodbye.
Thank you.
Thank you.
Thank you.